thank you very much for accepting the invitations to participate in this European event. Before giving the floor to the speakers of this event, I would like to remind a few technical points. First of all, I kindly ask you to unmute your microphone so that there are no noises on the background when the speaker will speak during the event. The other issue that I wanted to tell you is that event is recorded, and so it will be available later on our social media and also on our YouTube channel, and you will get via email the notifications that the registration is available for downloading or see it later. The third point regards the questions and comments that you wanted to share with all of us. We kindly ask you to put your questions in the chat, which is on the bottom bar of your screen, and we will answer them during the question and answers time at the end of the panel discussion. This is for the technical issues so far. Then I would, with pleasure, I pass on the floor to Mrs. Margarita della Pisa, MEP from the European Parliament, for a welcome speech. Thank you very much.
Thank you very much. Thank you to the Pancreatic Cancer Europe for organizing this event, and especially to Professor Alfredo Carrato, who have been supporting and helping me in my parliamentary work in BECA Special Committee, and also to the European Cancer Patient Coalition for your collaboration. I am honored to be here with you today and discuss the relevance of nutrition and well-being in pancreatic cancer patients. Today, on the World Pancreatic Cancer Day, we will discuss nutrition as a crucial factor for the pancreatic cancer treatment. And for that, we will count with experts from all over Europe. I am looking forward to the panels, and I believe will help alert about the risk of malnutrition in oncology. Unfortunately, nutrition is often neglected. However, is a key factor to tackle this disease, improve the efficacy of the treatment, enhance survivorship, and also nutrition has a great influence in the recovery stage. Nutrition is a crucial point. This is true for all patients of any given disease, but especially important in pancreatic cancer patients, as it affects the ability of nutrients. It is therefore crucial for them to ensure early nutrition care and continuing during and after the treatment. We need to give the pancreatic cancer patient more support on nutrition and fight against the malnutrition and weight loss. As a pharmaceutic and member of the European Parliament working in the Special Committee of Beating Cancer, we have been speaking and working closely with health professionals and different associations to be aware of the real needs. Thanks to the conversation with Professor Carrato, we were able to highlight the need of tailoring nutrition to the specific needs of each oncological patient. Have this included in the final document. Moreover, unfortunately, the European Commission in Europe Beating Cancer Plan did not mention this issue. It is curious that nutrition is taken into account as a predisposition and risk factor of suffering cancer, but then, on the contrary, there is inconsistency when the patients fall ill, and at that moment, the nutrition is ignored. For this reason, we decided to push and support nutrition, and this work has done, firstly, speaking directly to the rapporteur, asking to include these ideas. We have also tabled several amendments supporting ecological nutrition. For example, that the nutrition must be added as a fundamental, integral, and key part of an adequate treatment at all stages of the disease. To include oncological nutrition in the continuous training of all professionals, and to ensure the inclusion of a specialist oncology dietitian as a part of the multidisciplinary team. Also, to carry out specific studies on the influence of nutrition programs in this kind of the disease. We hope that this obvious evidence will be taken into account and will be reflected after work in the national health plans and benefits the patients. Lastly, thank you again to the Pancreatic Cancer Europe for your mission and work, bringing us together to raise awareness on nutrition and improve the care of patients with pancreatic cancer. Thank you for building this forum with relevant stakeholders to advocate for the improvement of the care, treatment, and rehabilitation of pancreatic cancer patients and their families. Thank you very much.
Thank you very much for your warm welcome and for the intentions to cooperate with our organizations for the sake of pancreatic cancer, and to share with us all the activities that you did in the frame of the European Beating Cancer activities. I would like now to give the floor to Professor Alfredo Carrato for a keynote speech on clinical nutrition as a part of the treatment pathway of pancreatic cancer patients and expert consensus. Thank you, Alfredo. You have to unmute the microphone.
Thank you very much, Luisa. Thanks very much, Ms. Margarita de la Pisa, for this excellent welcome. And we're going to talk about the relevance of clinical nutrition in a pancreatic cancer patient, as we think that it will has to be a part of the treatment pathway of pancreatic cancer patients. The next slide shows the outlines of the talk, which are malnutrition in pancreatic cancer patients and consequences, the outcomes of the nutritional intervention in pancreatic cancer patients, the supplemental parental nutrition in pancreatic cancer, the pancreatic cancer patient pathway, and finally, conclusions and take-home messages. I would like to start telling that there are many randomized clinical trials from the last 5 years showing that nutritional support reduces the risk for mortality and complications, and also improves functional outcomes in quality of care. For this reason, all the current European and American societies on enteral and parental nutrition suggest screening for malnutrition, nutritional assessment, and nutritional supports in patients with signs of malnutrition. Sarcopenia and disease malnutrition are underdiagnosed and are undertreated, as our parliamentary Margarita de la Pisa has recently said. In these hospitals, these wonderful hospitals we have in our cities, it is not usual to pay attention to the nutritional status of our patients. On the other side, physical exercise is recognized by clinical oncology clinicians for the potential role in reducing the risk of getting certain cancers, and also reducing the risk of disease recurrence after being diagnosed with cancer and reducing also the progression rate. This is due to the production of some myokines, which are cytokines produced by the muscle that have an anti-cancer behavior. The next slide is also about physical exercise. And we can see here that colon cancer, breast, kidney, endometrial, bladder, esophagus cancer, and gastric and lung cancer have a lower risk when there is physical activity in the population. And also that after being diagnosed of breast, colon, and prostate cancers, if the patient is fit and has a physical exercise activity, the mortality rate is lower, the recurrence rate is lower. So the benefit of exercise is supported on this data and also on patient report outcomes and symptom control endpoints that are very important in cancer populations. The next slide shows the different exercise parameters in intensity, in duration, in frequency, if it is aerobic or resistance, but the fundamental things is that it has to be personalized to the type of cancer, to the type of treatment, and to the related adverse events that the patient has. The exercise-induced myokines have a role in tumor suppression. The myokines also interfere with the adipocytes that improve the proliferation of cancer growth and inhibits the crosstalk of adipocyte with cancer cell, and also promote the infiltration and cytotoxicity of immune cells. So it's increasing the awareness of our proper immunological system. And the next slide is showing the different articles that are on cachexia and sarcopenia and pancreatic cancer. The two first are related to cachexia. As you all know, it's a multifactorial condition, is highly prevalent in patients with pancreatic cancer. More than 2/3 of patients with pancreatic cancer have cachexia, and early detection of signs and treatment of symptoms is of paramount importance. We have scales from many societies to see if the patient is malnourished. I want also to comment this interesting paper from Pierre Senesse that is present in this talk, that is able to use C-reactive protein and moderately and severely reduce food intake to predict independently overall survival. And this is highly significant. So the publication identifies clinical features and biomarkers that are associated with weight loss, some values for food intake, and the impairment of C-reactive protein. The sarcopenia, which is the loss of muscle. You lose muscle in your body. You can be overweight, but you can have no muscle at all and you can do nothing. So we have to avoid sarcopenia by a good nutrition, by a good physical exercise, and it's demonstrated that the hospital length is prolonged by sarcopenia, and it reduces the adherence to treatments and worsens quality of life and survival. If promptly supported, the patients may benefit from nutritional intervention in sarcopenia patients. The next slide is talking about the nutritional therapy that must be timely considered and prescribed since the beginning. We cannot lose time in that. It's a nonsense to wait until the patient loses 5 kilograms to start with a nutritional program. If oral intake is adequate, go ahead with him. If oral intake is inadequate, despite nutritional advice and oral nutritional supplements, we can provide supplemental enteral nutrition. If this is not sufficient for or feasible, supplemental parenteral nutrition should be considered. This is what is written at the famous ESPEN guidelines recommendations that were published a couple of years ago. Another paper is talking about the cancer-related malnutrition that is underdiagnosed, underreported, and undertreated, and this early intervention has a crucial paper on halting progression of malnutrition and improving outcomes in some patients. And there is a false idea that when people start with clinical nutrition is at the end of life. This is not properly understood by the society, because nutritional is a fundamental part of the cancer treatment in any patient. The next slide is talking about the supplemental parental nutrition that has a positive impact in the nutritional status and quality of life of patients with pancreatic cancer, as this paper says. And this supplemental parental nutrition enables the administration of tumor therapy without interruption, and in some cases, a success of the therapy. And this success is dependent on the patient's compliance, the availability of consulting, the support at home, etc., etc. The next slide is talking about early nutritional support and early supplemental parenteral nutrition. We see on the upper left side that when there is a weight gain of 2%, the curves of survival are quite different from those that do not increase that weight gain of 2% or even loses 2% of weight. So nutrition is of paramount importance for the overall survival of the patient. And the time between diagnosis and administration of nutritional support is an independent prognostic factor for overall survival. 3 months' time is a very big and significant time frame, and is a prognostic factor for a longer overall survival. Here we see at the bottom of the slide, malnourished and hypophagic cancer patients with contraindication for enteral nutrition, and all the parameters after 7 days of supplemental parenteral nutrition improved significantly with P's that were significant at the right side of the slide. The next slide is talking about the patient's preferences about the feeding process. Nasogastric tube can be perceived by the patients socially as fact that does not allow them to go to the street or to go with their friends, etc. So there is also an increase in the availability of better nasogastric tubes that are much thinner and that can be used for parenteral nutrition. But when this paper came from Escolapio in 2002, 91% of patients prefer intravenous feeding versus nasogastric tube feeding. And this happened also in the control arm where the patients were not cancer patients. And this paper from Escolapio was also referred at the ESMO guidelines in cancer cachexia from this year, that it has been proposed that patient preference has to be considered when deciding on the feeding method. However, we as professionals prefer to start with enteral nutrition always, and if needed, supplemental parenteral nutrition at home could be performed. The next one. The safety profile of home parenteral nutrition is demonstrated in these two big studies. The first one is a meta-analysis with 20 studies. It was published in 2019, and the incidence of complications were low, were catheter infection, mechanical obstruction of the catheter or thrombosis, but with a low incidence. And the authors conclude that this type of nutrition can be safely provided at home. The patient is much better at home, and it also saves money for the public health. The other paper was made last year in 2020 on 761 patients, and it also showed the safety of home parenteral nutrition, provided that the patients are previously taught and monitored at home properly. The next slide. Shows our experience in Spain. We had a multidisciplinary team made of surgeons, of endocrinologists, of nutritionists, of medical oncologists, radiation oncologists, that we have been working for a couple of years or almost 3 years to integrate nutritional intervention, both screening and support in pancreatic cancer patients. The screening tool that we propose is the MAST tool, which is quite simple. You see it on the right side. And this tool is taking into account the BMI score, the weight loss score, and if there is an acute disease effect score. And you have the score 0, 1, or 2, depending if you are losing less than 5 kilos, from 5 to 10, 1, and more than 2. And then you sum the 3 steps, and you have 0. This is a low risk. You have 1. You are a medium risk patient, and here are the recommendations to have. And if you reach the 2 or more, you have to be under the endocrinologist or nutritionist care to improve your condition, because you are at risk of cachexia and sarcopenia. We have published an expert consensus document that you can see here, and you can read in detail. And we have made algorithms and recommendations for nutritional approach. The next slide shows the nutritional approach in the patient with pancreatic cancer that is going to be resected. So these arrows indicate that the assessment must be performed at diagnosis and should be commented at the tumor committee. And if the patient is resectable and it doesn't go to surgery directly, it goes to neoadjuvant therapy, nutritional therapy has to intervene here. And the same if it's borderline and has neoadjuvant therapy, as well as it goes directly to surgery, from diagnosis, if it is malnourished, it doesn't make a huge difference to put the patient on a nutritional project for 1 week and delay the operation 1 week in order to get a good post-operative period without any morbidities. These arrows are like in the guidelines, the places where the nutritionist should intervene to go ahead with the quality of life and with the nutritional status of the patient. The next slide, it shows the objectives of this group, which is to achieve nutritional assessment as the fourth constant to consider in cancer patients. We only get the temperature, the blood pressure, the cardiac frequency, and we could ask, or the nurse could ask, have you lost your appetite, or have you lost unintentionally weight? And if any of those questions are yes, we are facing a nutritional problem, and this is the way to start working on it. The awareness of the society on this problem, as well as the health policy makers and sanitary personnel, the home physical exercise and enteral and supplemental parental nutrition is also our objective, to measure and compare results of nutritional status and intervention among different centers and situations, and to update knowledge on nutritional evaluation, treatment, and follow-up by sanitary personnel, patients association, and scientific societies. The next slide is showing that the results of nutrition is different because we have responders and non-responders, and nutrition is affecting the composition of the microbiota, which are the trillions of bacteria, fungus, etc., that are living within us. And this microbiota also is influencing the response of nutrition on the patient and making the patient responders or non-responders. So by utilizing both aspects, we could personalize nutritional strategies to modify the microbiome and improve the response to a specific diet. The next slide. So this is the last one. The previous one shows the unmet need of more funds to investigate on nutrition. And this one says that cancer-related malnutrition is underdiagnosed, underreported, undertreated, that sarcopenia that worsens quality of life and survival is found up to 65% of pancreatic cancer patients, 2/3. And the importance of early treatment is of paramount importance because it's an independent prognostic factor for overall survival. The efficacy and safety of supplemental parental nutrition is given when enteral nutrition is not feasible or enough, And the combination of both enteral and supplemental parenteral improves body composition and muscle strength in the absence of relevant complications, has a positive impact on the nutritional status and quality of life of patients with pancreatic cancer. 91% of patients prefer IV nutrition, and we call to action. We need to develop special clinical protocols to ensure adequate nutritional clinical management through the cancer patient pathway. Next slide says, thanks very much to everybody, especially to our patients, families, caregivers, nurses, nutritionists, colleagues from oncology and from any other medical and surgical specialty, supporters, MEPs, etc. Thanks very much to everybody.
Yes, thank you very much, Alfredo, for these interesting introductions to the issues of nutrition. I think there is a lot of information to process, and I really hope that the comments of participants that you can put in the chat, as I mentioned before, can contribute to the exchange of information and exchange of experiences at this regard. We move now to the next part of the program, which is a panel. We invited to the panel 6 experts on nutrition. And so I'm pleased to introduce to you Professor Carlo Lavecchia, from the University of Milan, and he is a medical professor of medical statistics and epidemiology. Then I welcome Professor Ilse Roman from the Free University in Brussels, in Belgium, and she is a professor at the Laboratory of Medical and Molecular Oncology. Then I welcome Dr. Pierre Senes. He is a coordinator of supporting care and head of clinical nutrition and gastroenterology at Cancer Institute in Montpellier, in France. I welcome Dr. Alfredo Budillon, director of the Experimental Pharmacology Unit at National Tumor Institute in Naples, Italy. And I welcome Mrs. Patrizia Radkowska. She is a survivor from pancreatic cancer, and she is a psychologist, a patient expert, and she's member of Europa Colon in Poland. And finally, but not least, I welcome Mrs. Cristina Sandina. She's the chairperson, the president of the Association Cancer, Associación Cáncer de Páncreas in Spain. So thank you for accepting our invitation. I would like to start asking Professor Carlo Lavecchia regarding his studies and his researches on cancer and diet. What are the relations that you can share with us between diet and cancer's risk, with particular attention to PCE?
Thank you, Luisa, and thank you everybody for your attention. Well, some of the association I will mention will probably have not only relevance as risk factors for pancreatic cancer, but also will have some relevance, as mentioned by Professor Carrato, in the prognosis of pancreatic cancer patients. I will start with overweight and diabetes because one of the clearest association after smoking for pancreatic cancer is a relative risk over 2 among diabetic patients, which in the first or second year after diagnosis of the diabetes is even higher. So it may reach 5 or more, and may also be used for supporting or indicating diagnostic investigation for pancreatic cancer. So, and I believe that that therefore the presence of diabetes may be an unfavorable risk indicators also for pancreatic cancer patients. Secondly, excessive alcohol consumption. So pancreatic cancer is not strongly associated with alcohol. Moderate consumption is not associated, but if you go to 5 or more or 6 or more drinks per day, you have some association with alcohol intake, and that's out of discussion. With reference to the most common aspect of diets, it is now clear that a diet rich in vegetable and fruit may reduce pancreatic cancer risk by 20 to 30%, while a diet particularly rich in red and processed meat may somewhat increase the risk. Again, you have to consume relatively large quantities of red meat or processed meat to see a risk, but this is certainly not a favorable diet indicator. When various foods and nutrients are put together in scores, for instance, there is a Mediterranean diet score, which essentially reflects the most common foods and nutrients present in the old Mediterranean diet. For subjects adhering more strictly to Mediterranean diet, you have a reduction of risk which may reach 40 to 50%, so relative risk of the order of 0.5, 0.6. And the same, there is a newer diabetes risk reduction score, which again is a combination of various foods and nutrients, and in subjects which adhere to such a diabetes risk reduction diet have a 40 to 50% decreased risk of pancreatic cancer, which indicates or at least suggests that these types of diet may have some value also for pancreatic cancer patients to increase survival and improve their quality of life. Thank you again, Luisa.
Thank you, Carlo.
Thank you, Carlo. We move then to Professor Ilse Roman with a question specifically on research. Can you share with us your experiences on the present situations of the research regarding pancreatic cancer and specifically its correlations to nutrition?
Yeah, thank you for giving me the word on this panel. When you say research, I would like to make the distinction between basic research and clinical research, and the clinical research part has had quite some attention by the keynote speaker and the previous panel member. So at the basic research side, I can say there is an established link between nutrition, both quality of nutrition and quantity, and I would say cancer in general, not necessarily only pancreatic cancer. So high-level studies have linked nutrition to inflammation, inflammation to tumor development and tumor progression. Now, in addition, fundamental research studies have demonstrated the connection between nutrition and inflammation and also anti-cancer immune response. So nutrition, I would say, can affect the incidence of pancreatic cancer as well as the therapeutic response. And lately, and it was mentioned before by Professor Lavecchia, I also see quite some studies on obesity and pancreatic cancer, diabetes and risk for pancreatic cancer, as well as the role of the microbiome. I think importantly, and it was a focus of the keynote speaker, the 80% of the patients is facing weight loss and associated cachexia. And cachexia obviously leads to lower quality of life, lower response to therapy, and reduced survival. Nevertheless, I see very little fundamental research studies on these nutritional aspects in pancreatic cancer. And it would be obvious to study the impact of nutritional cachexia, knowing that there are also experimental mouse models at our disposal that enable to incorporate this important topic in the basic research. Also qualitative aspects of nutrition seem to play a role. For instance, there have been reports on ketogenic diet that may stimulate the immune system and inhibit progression by interfering with the tumor metabolism. And again, I think it's been somewhat a neglected research topic. But yeah, in the end, the final goal is to translate the basic research into clinical research. And clinical research, we know in pancreatic cancer, is notoriously difficult because we're dealing with patients who are often not in the best condition, who do not have a long survival perspective. Nevertheless, I do believe there are opportunities that need to be worked on. The proposed work was a very good example that is a step in the good direction. There are important areas like the nutrition-based prehabilitation before the patients go to surgery. There is adapted nutrition protocols to increase the efficacy of chemotherapy. And I also think there is some preliminary evidence for nutritional supplements like fish oil that may harbor some promise and require further studies, both basic and clinical research.
Yeah, thank you, Ilse. We can hear now the voice of a professional active daily on the field of nutrition and pancreatic cancer. Then Dr. Pierre Senesse, questions to you. Can you tell us something about your approach to the nutrition issues with pancreatic cancer patients? How do you deal in your daily work life?
So thank you very much for the invitation. And so we have a lot of patients with pancreatic cancer. In Montpellier, we treat every year about 250 patients on average for pancreatic cancer. It's a huge part of patients. And also, I agree with Professor Carrato, of course, about malnutrition. Malnutrition is the main goal for us, for all cancer patients. And malnutrition is the definition is really clear now. Malnutrition is weight loss upper than 5%. It's clear. This is very simple, and we use only this part of screening. This is weight loss. And also the last publication as clinician, we use also the last publication from the National Consensus for Malnutrition that published a new sentence that we have a strong relationship between food intake and weight loss. That seems very, it's fundamental, in fact. If you don't eat, you have weight loss. It's easy to understand, but it's easy to understand when nobody screen if you have less food intake, and we have a very simple scale to use. You can ask if how much you eat today or on the last week, and it's done in 10 seconds. You have the information. If you don't eat, you'll have weight loss, and you can treat weight loss before malnutrition. And this is our goal and our screening here in Montpellier Cancer Institute for all patients, including pancreatic cancer. The other part of the information from Professor Carrato is pancreatic cancer is very aggressive tumor. And the meaning here for clinicians is the more aggressive the tumor, the earlier and the more aggressive the nutritional management should be. And it's really important to do that. As soon as possible, you have to screen and to treat all patients at the beginning. Of course, so we have a plan, of course, as clinicians with my colleagues here. We systematically have a nutritional assessment at the beginning of the disease before treatment for all patients followed for pancreatic cancer as soon as possible, include the weight loss, BMI, body mass index, and verbal food intake scale. And right away, immediately, we have to eliminate the causes that may contribute to weight loss, including, of course, the tumor. We have to treat the tumor, but also we have to look to unjustify food evictions. For example, some patients say that, you know, I cannot eat sugar or I cannot eat fat because it's dangerous for the tumor. We need to check that and to treat and to fix the problem to make sure, because this is a system, an error. You have sugar has not effect on the tumor. Your glycemia is really stable on the blood, and if you don't eat, in fact, the tumor eat into your body and use your muscles and use your fat to grow himself. So we have to check also diabetes systematically and to treat and to look for. And we have also to treat, and this is very frequent for pancreatic cancer, we have to treat digestive symptoms like diarrhea, and we use systematically pancreatic enzymes to prevent diarrhea or to treat diarrhea, because you have often maldigestion, malabsorption, because you have less enzymes in your body, in your bowel. So, and we treat also other symptoms that could impact food intake, like pain, for example. Then we have the nutritional support immediately for patients with malnourished patients, undernourished with weight loss upper than 5%. We systematically discuss artificial nutrition, not parenteral nutrition, but systematically enteral nutrition. First at all, oral supplementation with dietary counseling. We have systematically a dietary counseling for patients. We treat, therefore, if we don't have a good, you know, after 2 weeks, for example, you can have a new evaluation, and if the patient lose weight after these 2 weeks, you have to introduce artificial nutrition. We use all material we have, nasogastric probe, gastrostomia, all is good to treat and to avoid weight loss and malnutrition. You need to be upper than the tumor to have the chemotherapy and to treat the patients. And for non-malnourished patients, we have regular monitoring of the weight and evaluation, of course. And for all patients, we review the symptoms regularly to treat, and we encourage, of course, physical activity. Thanks.
Yes. Thank you, Pierre, for sharing your practices so in details with us. I would like now to move to hear the experience of Dr. Alfredo Budillon regarding how is the experience of your institutions working to relate nutrition to cancer treatment. And what do you do then at your research institution, specifically regarding the pancreatic cancer? Thank you.
Yes, good afternoon to everybody. Thanks for the invitation. It's a pleasure. And actually, following the speakers, we have an experience that follow the path of what has been described so far. Our institution is a comprehensive cancer center, so beyond hospital care, we have a strong program in basic translational and clinical research. And let me first mention a nice things that I think could be of interest within our discussion today. A few years ago, we launched a specific basic research program on the impact of Mediterranean diet on cancer development and prognosis and relation with treatment. And so to make a long story short, after some preclinical experience, we patented a new pizza. You know, Naples is the town of pizza, and this pizza is Pizza Pascalina because our institute is Pascale. And actually, we patented, of course, the recipe, and there is a website with the recipe and all the restaurants where the pizza is served, because the agreement that we have done with restaurants is that for each pizza sold, €1 return for a specific research program in nutrition and cancer. And there are restaurants all over Europe and world that adhered to this program. You can go and see the site. And by the way, the pizza, of course, contain tomatoes and broccoli, for example. Unfortunately, do not contain mozzarella cheese, which is typical, but because mozzarella is not so, I mean, it's good, but it's not directly related with our research program. Then beyond these things, I totally agree with some of what has been said so far. What we have been studying is the impact of diet and nutrition on cancer treatment outcomes. And in particular, like Dr. Carrato mentioned, there is a cross relationship between, for example, diet intake and microbiota. And these rely on the change of the metabolism in the patients. So we launched the program on Serum Metabolomics. So by blood sampling, we measure the alteration of the metabolism within the serum of the patients, because we think that this recapitulates exactly the change in microbiota, and we have evidence in this and the diet intake, and we try to correlate these with the outcomes after treatment, and try with diet intervention to change these metabolomic signature that we derived, and this is an important program that we have in our institution. On the other side, we introduce a program in drug repurposing, using some drugs that can have an impact on the metabolism. Such as, for example, metformin. The Professor Carrato was mentioning the relationship of diabetes and pancreatic cancer, and statin, which are cholesterol-lowering drugs. And after proof of concept preclinical study, we have currently some clinical trials, even in pancreatic cancer, using these drugs to modulate the sensitivity toward cancer treatment for the impact that they have on altered cancer metabolism. And briefly, this is some of the program that we are currently ongoing in our institution.
Yes, thank you. Thank you very much, Alfredo, for this interesting sharing of information. So I like the idea of having a specific special pizza patented in different European restaurants. And this is, I'm sure, a news that we like Patricia Rzadkowska. Sorry, Patricia, is your family name is
problem
to pronounce.
Yeah, I know.
For me. Yes, you are a former patient, you are a psychologist, you are a member of Europa Colon Poland, and so we are happy that you are here with us to share your experience, your direct experience on the pancreatic cancer and nutrition. So the questions to you is then what have been the main challenges that you faced in terms of diet and nutrition during your treatment period?
So hello, I'm Patricia, and thank you so much for the invitation. I'm very happy and honored to be a part of this panel. So back to your question, let me start with confession. I love eating and I like eating delicious. I like treating myself with food and it makes me happy, it gives me joy, and I have always cared about what I eat. So being diagnosed with pancreatic cancer and being in treatment and having some restrictions was really, really hard. I remember that day before I was admitted to hospital for surgery, I have demanded to have pizza for dinner because I'm a pizza lover. And for dessert, I've had pavlova, which is my absolute favorite. I was aware that I won't be able to eat this for a very long time. And even now, after 4 years, 4 years after surgery, I still have some limits. But I've learned that it's impossible, actually, to eat myself up ahead. So nutrition was really significant. It was a matter of strength in every way possible, from physical, when I've lost energy and power, to mental, when I was experiencing some anxiety and depressive state. I kind of feel like I have lost something and that it won't come back. Even if I beat cancer, I would have pancreas after surgery. So actually now I have only 1/3 of my pancreas, only the head of this organ. So they got no diabetes right now. But actually now I have, so I was aware that my life and nutrition will have to change. But I wasn't really ready for those changes. I was adjusting to this everyday passing, and I had to learn how to live with this new way of life. So I also believe that I should mention that after surgery, I've experienced some side effects. My pancreatic duct was cut out and pancreatic juice was literally flowing out of me. So I've been in a hospital and I've spent there almost 5 weeks after surgery. I wasn't allowed to eat anything. And due to that, I've lost about 12, 14 kilograms. I was just getting some IVs with basic nutrition. So I was losing my strength rapidly, to the point that I even passed out in hospital bathroom. And that was the moment when parental nutrition was given to me. And a few weeks later, I had a stent placed in my pancreatic duct, and I was discharged from hospital and went home, but with another prize, anemia. Main difficulty was the fact that I was extremely exhausted, didn't have any energy, I had apathy, was tired all the time, and I had to find some foods that would be okay, delicious for me, but wouldn't cause any problems to my pancreas. So after weeks of trying, I've grown love to steamed vegetables, dairy, plant alternatives, healthier substitutes of sweets, like low sugared. I've started enjoying fish and eggs, which I've hated before. And also when I, even now, when I eat something that is inappropriate without knowing it, my organism immediately let me know about it. I've had some abdominal gas, nausea, diarrhea, some cramps. So I'm literally feeling that I'm not digesting okay. And sometimes if I know I'm about to eat something harder to digest, I take pancreatic enzymes before meal, but it's of course prescribed by my gastroenterologist. I don't take any drugs without consultation with my doctors. So the harder part was, and still is, not to think about it as a diet, as some restrictions that I have, but to treat it like another way of nutrition, another way of life, actually, that helps me stay healthy. Due to surgery on my pancreas, I was asked to monitor my sugar level and try to eat food with low glycemic index to prevent problems with glucose and insulin balance. And I was also recommended to cut out sugar as much as possible, which is super hard for me as I have sweet tooth and I love chocolate. I believe there is chocolate in my veins instead of blood, actually. And the best advice that I have received was to monitor myself very carefully, how I felt after a certain type of food, what made me feel bad, what was okay. I even had an eating journal, let's call it, where I had been writing down all my meals and observations, side effects I was having. It helped me to find food that were not okay for me. For example, I've reduced fried food, reduced fat, obviously not completely because we should eat it, as some vitamins dissolve in it. I've also reduced spicy food in order not to irritate my pancreas. So basically, everything that might be hard to digest. And I love Italian cuisine, so believe me, life is really hard with pizza, cheesy pasta, and glass of wine. So maybe I should just look for this pizza recipe that Alfredo just mentioned a few minutes before.
Yeah, so thank you, Pat, for this interesting sharing of your experience. I'm sure that this will be of help for any other patients now that is undergoing this illness as you have been done in the past. Well, now we can hear to the voice of a patients' organizations. So welcome to Cristina Sandin. She's the chairperson, the president of Association Cancer de Pancreas in Spain. And Cristina, the questions to you is what is, in your experience, the difficulties that your association is having in supporting pancreatic cancer patients, in driving them towards an appropriate diet? Can you share with us some experiences?
Well, thank you very much, Maria Luisa, for giving us voice in this panel, and also for to give the importance, the huge to the huge problem for pancreatic cancer, this huge problem for pancreatic cancer patients. Pancreatic cancer patients find it difficult to have a proper diet on many occasions, even before being diagnosed. Let's not forget that one of the symptoms of pancreatic cancer is unexplained weight loss. And there is where patients are constantly in situations for them inexplicable. There are some difficulties and needs of pancreatic cancer patients to improve their nutrition and consequently the quality of life during the disease. And I would like to highlight some of them. The first difficulty of pancreatic cancer patients, they feel lost in this new situation. They have too much information, changes, ignorance, and no one is guiding them in a global way on how to deal with this disease, how to manage it, to have the best quality of life as possible. So they can feel very frustrated and helpless due to the lack of proper explanations and information about what is happening then. They need to understand what is going on in order to act accordingly. So they need someone to give them global orientation and information about all the processes and how to act, how to take care of themselves. So the first difficulty that the pancreatic cancer patients find is the lack of global information about the disease and how they should take care of themselves. They need someone who coordinates the treatments, someone that gives the patients all the information in a global and coordinated way, and it doesn't exist now. So let me read some quotes from patients. Mm-hmm. So one patient says, generally, nothing is explained to patients, even when they ask. I think it is very important to take patients into account and talk to them in order for patients to both understand more about what is happening to them and to contribute more. This is a pancreatic cancer that suffers from cachexia. Mm-hmm. So in second place, there is a need, nutritional support is necessary in a preventive way, in the diagnosis, and coordinated, of course, with the oncologists and other specialists to avoid the malnutrition and cachexia, and to facilitate the quality of life of the patients. They also need specialized and personalized information about nutrition in pancreatic cancer and about cachexia, so common in patients with this tumor, as Dr. Carrato said. Patients do not know how they should eat. They need dietary patterns. They need weekly diets specific for them. It is essential for them to feel confident that they are eating adequately. Due to this lack of appropriate information, it is usual for the patients to make mistakes when it comes to what food will make them feel good and help them to nourish themselves properly. So as a result, the feeling of helplessness is very usual in pancreatic cancer patients. Another difficulty we find is that there is a severe lack of professionals specialized in pancreatic cancer nutrition and in cachexia. Therefore, there is a need of endocrinologists, nutritionists, and gastroenterologists, but specialized in these disorders. Let's not forget that the normal thing that these professionals used to be specialized on is that people lose weight, not that they gain weight. So professional training is needed. And finally, patients need specialized psychological help. The persistent weight loss, coupled with the inability to gain weight and the lack of proper solutions, can lead to frustration, depression, and anxiety in patients with malnutrition and cachexia. Let me read another quote. In my case, it has caused me anxiety that makes me eat compulsively and exaggeratedly obsessive manner without any results, leading to more digestive problems for not being able to control myself. I think these are the difficulties that we can find for pancreatic cancer patients to have the proper nutritional diet.
Yeah. Well, thank you, Cristina, very much for this in-depth overview of the difficulties that patients can face during the treatment and during the course of the illness. We were thinking to have a second round of questions, but the time is running. I see it's already 38 past 4. And before going to the question and answers time, maybe Cristina, because we know that your association has a good, a very good practice, in supporting patients, pancreatic cancer patients, and in terms of nutrition. Maybe you can tell us what is the best practice that you developed in your association?
Well, in Spanish, in the Associación Cáncer de Páncreas in Spain, we're aware of the importance of diet and correct nutrition for the quality of life of pancreatic cancer patients. In 2015, we launched the Diet and Quality of Life Guide for Pancreatic Cancer Patients, which is the guide. So our objectives were to give them a global information about the disease that they should so badly need, to facilitate the daily nutrition, and give them the necessary guidelines to maintain the quality of life and as best as possible during the different stages of the disease. The first edition of the guide was made by 10 authors oncologists, endocrinologists, nutritionists, psychologists, and specialists in sport medicine. And well, we think that this guide has been a really great success for both patients, their families, and health professionals. Has told us that they use it in their day-to-day lives. So the guide has 2 versions, digital and paper, and we are now working on the 3rd edition of it, in which we are updating the contents, and they will participate, in addition of the authors of the previous edition, nursing professionals and cooking schools and hospitality that have participated with the recipes that we have included in this new edition. And as we wanted the patient need delicious, not just adequate food.
Yes.
With the first edition, we developed, in addition to the publication of the guide, we organized 3 face-to-face sessions under the title of Food Does Matter in Pancreatic Cancer. And these sessions, in addition to giving all the necessary information that they had in the guide with oncologists and endocrinologists and nutritionists, we invited prominent chefs with Michelin stars and participated. They participated and taught us how to cook healthy, easy, and delicious dishes as well.
Yeah. Thank you. And so the guide is in Spanish. Then
yes.
It is you can download from your website. Maybe you can write in the chat the link where people can download the guide if they speak Spanish, of course. But
yes.
I'm sure that some persons will be among us that speaks Spanish as well and might be interested in this guide.
Sure, I will put in the chat
yes.
the address. Okay.
Thank you.
So
it's now time for your questions. If you have questions to our panelists or to Professor Carrato, is time now to write in the chat. Or if you want to write.
I would like to ask either Ilse or Alfredo Bodillon about the unknown microbiota, that it's influencing the appetite, it's influencing the weight loss, etc. Do you foresee how can we manage this? Because I have read an article in Melanoma where the population was treated with anti-PD-1 and 30% responded. Those who did not respond received fecal transplant from those who responded and were treated again with the same drug, and half of them responded. So maybe a kind of manipulation like this could be feasible to increase the ability to well nourish our patients, because it's quite complicated. Many factors, cytokines, microbiota, etc.
Yeah.
What do you think about that? Because you know more about that.
Yeah, Alfredo, if I can say something, because of course we have been working in the institute with Paola Scerto, which is an international expert in melanoma. So we are aware of these and we participated in some of this trial. The problem is that the macrobiota signature that was published associated with the good outcome or poor outcome in response to immunotherapy, for example, by different authors are different. In other words, there is an heterogeneity, so there is no one signature. And this is because, of course, the microbiota can evolve even under the pressure of treatment. That's why we moved to metabolomics, because we think that this can recapitulate the alteration in microbiota. And so we are trying to, and we have some signature, for example, in melanoma patient of serum metabolomics at the start of treatment and then after treatment that predict some outcomes. And we are thinking how to manipulate this metabolomic signature, and then, of course, even the microbiota to potentiate the treatment. Is a very exciting and interesting but difficult fields, as you mentioned.
Yeah, maybe I can also add something, although it's totally not my research area, but I think the extra complexity in pancreatic cancer will come from the fact that we don't have a responsive patient population to use the microbiome from or to go for fecal transplants. So that, and also because of the highly different nature of the tumor, I don't think we could easily go from, let's say, responders in melanoma and then go to pancreatic cancer patients, because the tumor biology is so different that for many therapies that have worked in other tumor types, it did not work out well in pancreatic cancer.
Well, if I can add something, the microbiome and microbiota are certainly very interesting and innovative fields of research. I am still uncertain whether there are now practical and clinical application on pancreatic cancer patients. That's an open issue. Thank you.
Yeah. Well, Carlo, there is exactly a remark from Nuria in the chat saying, I wonder about the epidemiological and clinical research to be done to integrate the many factors you mentioned as involved in risk and progressions of pancreatic cancer, diet, diabetes, obesity, drugs, microbiotica. I don't know if you wanted to add or comment on this remark.
Well, again, is not easy now to integrate, probably more than what we try to do with the dietary scores of the Mediterranean diet, or diabetes, the anti-diabetic diet. I believe that's again a research ahead. So try to integrate both in the quantification of potential risk factors and the approach to patients with pancreatic cancer, to integrate various issues, including microbiome, including possibly selected genetic factors, and so on and so forth. Because what is really missing now is progress in the management of pancreatic cancer. It's really very, very modest. It's one of the neoplasms in which the progress has been small, and we have to do all what we can both to obtain attention and consequently research funding for this important part. Cancer has already become the third cause of cancer death in the European Union. So it's a very important neoplasm, and we need to attract additional funding for understanding, for managing it. Thank you again.
Yes, thank you, Carlo. Yes, Alfredo, please go ahead with your question to Pierre.
Yeah, I had a question for Pierre, because like he mentioned, and like other institutions, we assess all pancreatic cancer patients, like other cancer patients, within a dedicated multidisciplinary oncology group with a dedicated nutritionist for first assessment with questionnaire, body mass index, and so on. And recently, we introduced body bioimpedance analysis and try to have a specific assessment in this way of nutritional state. So I just want to comment on this and what he thinks as a nutritionist of this approach.
So I think it's really important, essential to have, malnutrition is a complex, it's a multi-evaluation. You have weight loss, this is the first part, and you have also muscle rarefaction. And you say that you have an evaluation for that by you can use DEXA or CT scan, doesn't matter. And the muscle rarefaction defection is really essential because this is in direct relationship between muscle mass and side effects for chemotherapy. In fact, we think with Vicky Barakos that the drug, we have only one pharmacokinetic study in the world published by Mia. And, but when you have deficiency of muscle, you have a lot of chemotherapy in the blood and you increase significantly your side effects by chemotherapy. So we need to check that, and but I don't know how you can treat. you can have a diagnosis, you can reduce your level of chemotherapy, and we have a randomized study here. This is the end of this study in the middle of this year, because we compare the drug of chemotherapy, the level of drug of chemotherapy adapt to muscle mass for colorectal cancer. It's not for pancreatic cancer, but it's the same, it's ciloxatine, and we use often for pancreatic cancer also. And I think but I don't know how we can increase your muscle mass. Probably exercise is a way, but I'm not sure that we need to have other ways to increase that, I think.
Yes, thank you very much, Pierre. So, if there are no other questions, I would suggest to move to last part of our program. We have a video message from MEP Sokol, just to conclude this event. And Tomislav Sokol is a European parliamentarian. He belongs to the group of the European People's Party, and he's from Croatia. And he is also a member of the EU Parliamentarian Intergroup Challenge Cancer.
I'm very happy to have been invited here to share my views on this hugely important topic. I would also like to thank the Pancreatic Cancer Europe and the European Cancer Patient Coalition for holding today's event. Pancreatic cancer has the lowest rate of survival amongst all cancers across Europe. In the EU alone, it is responsible for over 95,000 deaths every year, and life expectancy at the time of diagnosis is less than 5 months. Therefore, I'm glad that we can discuss the importance of nutrition as a crucial factor for the quality of life of pancreatic cancer patients from the very first moment after the diagnosis. In the last years, there have been several initiatives to raise awareness of nutrition for cancer patients, as it is a crucial component of care, treatment, and rehabilitation. Early nutrition care plays an important role in pancreatic cancer treatment, being crucial before, during, and after multidisciplinary management. Pancreatic cancer patients need more support on nutrition, as side effects or symptoms such as loss of appetite, malabsorption, nausea, and vomiting can cause the patient to consume fewer calories than the body needs to maintain an appropriate weight. The Beaten Cancer Plan thus supports the development of innovative treatments and efforts to advance personalized medicine, focusing especially on cancers with poor prognosis, such as pancreatic cancers. At the very heart of the European crusade to beat cancer lies the Strategic Agenda for Medical Ionizing Radiation Applications Action Plan, aiming to ensure that EU citizens have access to high-quality radiological and nuclear technologies in medicine at the highest safety standards. Furthermore, as many of you are fully aware, a key segment of the fight against cancer is its prevention, which also includes a healthy diet. That is why, as the EPP's shadow rapporteur for the Farm to Fork strategy in the INCO committee, I strongly advocated the introduction of mandatory and harmonized front-of-pack nutrition labeling scheme. This will make it easier for patients to choose healthy foods based on reliable information. I therefore look forward with great interest to the legislative proposal on nutrition labeling envisaged by the Commission for next year. Once again, I would like to thank the organizers for raising awareness of this topic. We must continue our work to make sure that frameworks we draw up meet needs of all patients across Europe. Thank you.
Yes, thank you to all of you that participated in this event. I would like Alfredo Carrato, Professor Alfredo Carrato, if you would make some conclusions out of this event. The floor is yours. Thank you.
Thank you, Luisa. I am really happy that 150 people just attended to this symposium, and this is an achievement that increases the awareness of nutrition in this special group of patients, because we need money from the European funds to know why these patients feel so tired and they cannot make physical exercise. Why do they feel without appetite and they cannot eat at all? So there's much work to do that needs to be done and for the benefit of our patients. It's important to make awareness of these needs. This is the tumor that is less developed regarding treatment when we compare them to the others. We have not any targeted treatment like Herceptin for breast cancer, like many others for the other cancers. This is the only one that are treated with chemotherapy. And I don't think this is fair for the 21st century. We need a lot of support from your side to make our struggle against this disease more efficient in the benefit of our patients. I would like to thank all the sponsors. I would like to thank everybody that has been talked with excellent talks and excellent points of view. And we invite you to work with Pancreatic Cancer Europe. And we are a small family that is intending to grow, but just with the objective of making the life of our patients with pancreatic cancer easier and better every day. Thanks a lot for your valuable contribution, and I wish you a pleasant evening. Thanks a lot.
Thank you, Alfredo. Before closing the link, just some technical information about the report of this event. Both the slides presentations and the registrations of the event will be available online. We will prepare the documentations and send to you the link via email. So we have your registrations email so that you can download the documentations and you see the recording also later on. So also from my side, thank you very much to all of you that attended until the last this event. It has been very insight and interesting from many points of view, and I'm sure that we will cooperate further on these delicate issues as it is nutrition. So thank you very much, and stay safe, and we keep in touch. Bye.
Thank you. Bye.
Bye-bye.
Bye. Thank you.